Sí. Good morning, everyone. This is one of the last talks we're going to have within this Congress. Right now we have the psychologist, Andrea Fernández. Good evening, everyone. Thank you very much. I'm going to share screen right now. We're having technical problems right now. Okay, well, again, sorry for the inconvenience. Thank you very much for this space. As I was saying, I work right now in the National Patronage of Infancy. That's really important within kids in Costa Rica. This usually creates the policies of formation for kids and teens. This gives us the possibility to work within vigilance of all rights of infants, kids, and teens in Costa Rica. This is wonderful because it helps us to coordinate the opportunity that all institutions within this country can bring reports about infancy and give kids and teens some kind of prevention with their health in Costa Rica. As Andrea was saying, well, right now, Costa Rica is in the process of validation or formulation with a new policy with kids and teens. It's not like other countries like Mexico, but we are now having an opportunity to create policies with institutions that to help these kids and teens. We are now working with underage people in the process of creating these policies. So this is work directly with kids and teens within our country. So we can now have a perspective of what kids and teens are asking of us as an adults, with the prevention of their mental health, promotion of their mental health, and overall attention. So this is really wonderful for us to have that responsibility. So now I want to begin this talk to give the opportunity to everyone to know the country with this map that is a little bit small. But what happens so you can see what happens with prevention and promotion with this country. So Costa Rica has two countries aside, Panama and Nicaragua. So that's really important because a lot of people come from the south in their trajectory going north to other countries. So we constantly have a flux of people that migrate and creates a whole new problem, especially for underage people are migratory, which is a little bit more serious in that matter. So that we have to make that association with migratory people, and we also have a country that we can travel through in practically hours from one coast to the other. So we have the opportunity. We have amazing beaches, really beautiful beaches, that give access to really beautiful, really abundant tourism, and with the relevance that can have. That also gives the opportunity to kids and teens to have access to stuff that they don't really normally have access to, like drugs. So all that tourist movement can also bring some kind of unwanted attention. Another type of inconvenience that our country has is pretty complex by economic problems. That implies that some teens, kids are in risk of not corresponding to the life process that they need. So continuing, we have that by a political constitution, the national patronage of infancy has the job of protecting the kids within our country. So we have to be very vigilant to keep the protection, not only to children, but to the mother too. So we have a pretty wide range of people that we have to take care of. So to have that possibility of to see how our country works with this mental health problem, we have this what we call a system, a national system of protection for kids and teens. This system consists of 24 institutions approximately. It's not that big, but it's really pretty important. It's a pretty important number where it all joins this representation of each institution, and they make decisions in relation to kids and teens in our country. This deliberation and take of decisions helps us to help in the work process of attention and prevention nationally. There are some institutions like the patronage that we all already talked about, the Ministry of Health, a whole lot of institutions that work with the government and are non-government-like, that work conjointly for the protection of kids and teens. So in that sense, this is kind of like an umbrella that makes us work in coordination to have a vision, work vision in each one of these institutions. So now, giving context to what's happening within this country, we have the history, for example, that if we start talking about all the process that are these effective processes that are affecting, we could talk about it all day. So basically, I'm considering important that we need to make a history of what is called the depression in this case within all these age groups represented in 5 years. We had the opportunity of having all of these data of all these institutions because, let's say, the Social Security, places like the Social Security can have the opportunity of classifying it. That can help us giving a diagnosis to our kids and know how to help them. So now we are seeing in screen from age, really early ages from 5 to 9. Now we have to take into account that we don't have a really big amount of people like Mexico, but let's see, in 2017, there was about 499 individuals from age 5 to 9 that were depressed. And we know that has increased around 2021, and that's mainly to the pandemic, because we had our kids within inside their homes. And they didn't really go out much, and we have while as the pandemic advanced, we could see that the data diminished, and that's because it made it pretty difficult to take account of all the kids that were inside their homes, and that made it pretty difficult to make this populational diagnosis. So with these important numbers, in the case of 10 to 14, we can start to see the same numbers diminish. There are a lot of factors to take into account. We have a lot of benefits in the matter, but these are pretty selective analyses in each of the age groups. So now continuing with the report. In relation to self-harm, this is when we start to see and start to paying attention to the stuff that's going on. We have the opportunity to see that in Costa Rica, women are more likely to self-harm than men. It's a situation that, for example, in a history of 5 years, like we already saw, we have a report this report is thanks to the emergency services in our country that make a history nationwide that helps us have all this data of emergency services helping people. So like in 2020, we can see it diminished again with the start of the pandemic and start rising again, because all of these emergency services couldn't make a register, but as all of it started open again, we can see a rise because they started being registered again. In this table, we have the opportunity to see how in a history of suicidal thoughts and self-harm, again, we can see this difference again by the emergency services of our hospitals in this historical register. We also tend to have a lot more in the case of women, having like in 2019, 13 women, 12 men, 2020, 24 women, 15 men, etc., etc. And that's only with suicidal thoughts. If we see that all self-harm have pretty important numbers that are pretty important to take into account, just as much as suicidal thoughts, self-harm. We have to take into account that this can be caused by a clinical intervention that's not thorough enough, and this can create some kind of mode this makes it difficult, especially in schools, that expresses itself in real clinical expressions like self-harm. We have to take an account of that light that's present in suicide prevention. So now that when I presented this map, it was not just to share my national pride, but it was also to do, so you can see that in that providence level, we also have those data. We can see the visits to the hospital, people underage, that, well, while these data are not really that alarming, what's alarming from this is that us as a country, especially in our capital, now that we are on the process of forming of political stuff, we can see the difference between the problems that affect individually our kids and teens according to geographic zone which they are located. It's kind of like when we see from country to country that we have different stuff that affects us. But this is within context of Costa Rica that we can see that within our capital, there is a lot more situations of violence and a lot more situations where mom and dad go to work and kids stay with family, or they even stay alone, and that they start to present symptoms. So other affections or situations that we can see, that we can find within our other zones of our country. So now, according to emotional situations, there are a lot more reported within our capital. We have similar situation within men in all of our provinces, but we still have a lot more women being affected by this within all these provinces. So now with hospitalary visits, it's not only with UCI, but now we're taking as an account people who had an affection that was a little bit more serious and needed a full-on hospitalization. Right now, we only have there are provinces that only have one hospital for all of them. And this also affects the numbers and the people affected. We only have one national hospital now. Even if we have hospitals specialized in kids and teens and dealing with all of this stuff, there is a lot less staff specialized in dealing with these problems specifically. So even then, they require the only national hospital that we have. So we have also to consider that even with these low numbers due to pandemic, with stuff starting to be open again, those numbers, even if these kids are starting to meet each other again, starting to socialize a lot more, and being able to deal with stuff a lot more easily, these numbers still start going up. So clearly, we have, and we expect that we're going to have, or even are having right now, higher spikes within these numbers. Some of these kids even have PTSD because there is a lot of stuff that happened to them with them not being able to go out and even dealing with sick people or even dead people and death in the family. So now talking about suicide properly, we have the total historical total within men in Costa Rica. This causes me great pain because even if these numbers are low, I think no country should have any real number, especially in young ages like that, like this. This is really painful to find out that, for example, last year in 2021, we had deaths in really, really early ages due to suicide. And to have a suicide, even if it is just one of 7 years old, it's really a call to see what's going on in people underage. What are we failing? What are we doing that really causes an early age, causes suicide at an early age? So like 2018, 11 kids, 2019, 24 kids, 2020, 17, and finally 2021, 17 years old. 17 people dying of suicide. Now, with women, we also have in 2018 a kid, 10 years old. Here we also have this, like, what's going on? What are we doing wrong that's causing these suicides? A process that their hope to live ends up in situations like this. Why are we not preventing this? With a kid that sometimes just doesn't even have that concept of death, of or life, or what's really the cause that we cannot be preventing all of this. 2018, 9 kids, 2019, 4 kids, 2020, 10 kids, and 2021, 7 kids. So suicide in Costa Rica has ended up being the 3rd cause of death. And to have a 3rd cause of death as suicide, it's really paining me. And that's why I'm saying within this talk that it's really important for a nationwide to work on this problem. So to me, it's really important to make a history of how these institutions within that integral, that big umbrella that we were talking about, with institutions working on prevention, how can we intervene to clearly prevent not only that we have like anxiety or depression, so they don't develop that when they're adults, but also that how can we prevent depression? So we have a lot of colleagues that have been having these trainings. There's a lot of people who are really well formed, who can really do well within this prevention, because we have a lot of people coming from everywhere to work within this suicide theme. Now we have this Ministry of Public Education within our country, who has a great quantity of functionaries, and that gives us an opportunity as a public worker to have people who sensibilized, who has this empathy with motion of prevention, to deal with the people at risk who is underage. And here in Costa Rica, we have a free basic education. So we have a opportunity to incite within all of these kids who are going to school. So that even the ministry and us within my sector can work and have this prevention within these kids, and really be preventing this suicide within kids. So the prevention level within the Ministry of Public Education, they are working with protocols so that we can work on these kids. All of these booklets that you're seeing right now are some of the protocols that we currently have, that we can give to teachers, so that, well, teachers that teach in each one of these schools, from the capital to the farthest point on our country, because we also have indigenous sites that are very important. So all of those teachers have the opportunity to work and understand each situation with these kids, these underage people, have a protocol. So we can even have this protocol to capacitate all of these teachers, and they can work with different protocols in these different situations. And so we have protocols in bullying, protocols in teenage pregnancy, discrimination, xenophobia, prevention of suicide, guns, drugs. We have a lot of protocols that allows us to work early and within all of these institutions that intervene with this underage individual. We are having difficulties because sometimes there's lack of sensibilization. There are people who are not sensible enough to what's happening to a kid. So we need to work more on our teachers being sensible enough, and have all of these protocols, that ABC, on their memory, and being able to use them in each moment. For us to attack and prevent in all of the situations that clearly affecting all of our kids and teens. We also have, at a consumption level, an institution that works or intervenes within that consumption of alcohol and drugs within our country. The advantage of the institution of this institution, we have one that works not only in adults, but also in teens and kids. All of these programs, like the IAFA, sometimes it is difficult to give access to teens and kids. And I say teens and kids because it has been known within these numbers that the consumption of drugs and alcohol is increasing in more earlier ages, to ages like 12, 13 years old. So in that sense, we have the IAFA that has a process that's even in an attention level. And we have a situation of consumption related to underage person. We have that in 3 months, they're going to have to receive clinical psychological medical attention, specialized. And then assure that they are going to school and having the proper attention that they need. So we can have this situation where we have a dual pathology that maybe it's not on just that they have that chemical dependency, that addiction, but also can be affected by an emotional problem, a social affection that determines their emotional state, their psychosocial state. So that dual pathology, what's required is getting them to a specialized hospital, which makes it a lot more difficult because sometimes they are in that situation that, well, I have to treat this underage person, but I don't have enough space in the hospital to treat them. And right now, us as a country, that's something that we need to take into account to really start treating this problem. And so we only have one institution that has consult and has that possibility of training that we're doing. And that's in our capital, not in our provinces, which all of these people that need to be trained need to migrate to our capital, to the central part, and so they can be trained by specialized staff. So we have this part of the social security that can treat pretty much everyone, migrant people coming from the south or people already within our country. And we have, even though we have a public service for people that's free for people who cannot afford it, this section specifically has it is obligatory for them to treat people underage, no matter what situation they're in. So we have these teams like general medicine, infirmary, primary attention that they spread everywhere from the country to anticipate risk in mental health. These basic teams they have they have the obligation to assess all of these risk situations that and detect them and that our kids and teens are having. To make questions like if they have had sexual relationships from what age, the consumption of alcohol or drugs, and to determine the psychoactive state, if they have had suicidal thoughts, tendencies, self-harm, if they have the ability to adapt and to make that assessment to see how the clinical staff as a whole can take them to, can treat them by themselves or take them to an institution that's a bit more specialized. We have also situations where we have to treat them with their mom and dad. And well, that makes it pretty difficult because sometimes a kid doesn't want mom or dad to find out that they're taking drugs or alcohol or whatever. And that also can be pretty difficult because it affects that emotional state. So it depends a lot with this team to see if the kid is pretty depressed or to see how they can assess these kinds of situations. We have a second model of attention that are these clinics where we have a secondary treatment where they can determine if the person has to be referred to psychology within these clinics. And clearly, when it's something a lot more serious, to be considered like psychoactive affections combined with other situations with this underage person, like violence within the family, they don't have someone to talk to. Well, it can activate this system and to see if they can treat them to a hospital, psychiatric hospitals or somewhere where they can get that treatment. So another thing that we can see, another problem is that we have high demand, but a low ability to assess that demand. We have clinics where there's only one psychologist that can attend to that specific clinic. Sometimes by a large number of people, a pretty large number of people, we only have 3 psychologists. Well, sometimes even along with this, the medical model prioritizes the physical health more than mental health. And so we have to also change that to be able to assess and treat them. Because this creates a lot of more problems, and we need to be able to deal with all of this demand, all of these problems, to give the right treatment to all of them. I have given myself the job to make investigations to assess these problems, of the problems that has this specific sector of the social sector. It deals with healthy lifestyles. Problems that have been affected by stuff like the pandemic. Through the pandemic, we have had all of the psychologists also working to assess all of these mental problems. So Each of all these health sectors have worked not as a structural problems, where we have indicators of the impact that our programs have had. We have now, well, sometimes when our kids are being hospitalized, we need to ensure that they have that process of psychotherapy, that education. We need to make a social assessment, and so that they receive the drug therapy that they need and not something that harms them. So within hospitals, we see a pretty young person that's hospitalized by a situation within their family, emotional problems related to, I don't know, whatever the situations that you can imagine. He doesn't have, well, a proper follow-up because of all of this, the demand that all of our psychologists have. So some assessments can be pretty good, while others are pretty not. Clearly, all of these people who just all these people that will lose education, lose their friends, lose gets far from pretty much everyone, have that tendency to fall off again, all because the psychologists cannot treat everyone equally because they treating a lot of people, a lot more people that, well, they should. So now a preventive level, we have this situation, this risk situation that has high demand, attending violent situations, even within the family, that, well, if they situations where we have to go act. The PANI, the institution that deals with all of this, have offices within all of the country. So we have not only situations where they have to make they need to go and report the situation. We also have emergency lines where they can do that. We have the opportunity to attack early the situations that are affecting underage people and to intervene with an effective response within all the situations that are violating their rights. We can intervene, and clearly the consequences can be lower. So now this sector, the PANI, within all of the situations of violences, and many of them that they can have, we have lawyers that work with the family, and help the family, I don't know, to work with the system of how not to have physical violence, verbal violence, and any kind of violence. We have a lot of work in the social, educational part of, and well, while we need to upgrade and be better, we still have all of these parts that can intervene in an early stage. sometimes if we see that it's required in health, if we know that there's a situation of drug consumption, we refer them to the IAFA. If we know that they have an educational problem where the Ministry of Education is not doing their job or somehow not respecting that individual in question, we make a report to the Ministry of Education so they can assess that problem. And so that's pretty cool because it's somehow great that here we at the patronage of national patronage of infancy, we kind of coordinate all of that so they can prevent and promote the health within all of our kids in this way. So now we have been working a bunch of years in promotion of this intervention, this early intervention. And we have some programs to intervene within all of this that are just 8. We have a basic team of psychology, basic education, specialized education, and occupational therapy. They are installed as a unit, as an institution, a center in the more difficult zones within our country to work with underage affected individual. So they are more like a primary intervention more than a specialized one. Sometimes even as a secondary intervention to work with this promotion. And to promote all of this is meant to promote these abilities for life. So somehow we have situations of low economical stage, all of this situation of people who doesn't have that education because the zone in question that they live in has a lot of gun, drug problems, and that situation makes us sometimes unable to work with these kids and teens. So that sometimes kids just get farther and farther from our reach to help them, and that makes it more difficult. So that's why we have these units that don't aren't really meant to replace us, but as a way for us to reach there and help them, even if they are not right here in the capital or within zones that makes it easy for us to work with them. And so, these kids have the opportunity to talk to a psychologist, and our basic team makes an assessment, so they can even refer them to a specialized institute that can help them. This program is pretty wonderful. I love it. It's pretty important. And I hope that we can make it grow a bit more. We have mobile centers that, in a bus, they travel to the furthest point in our country to make these promotional activities in the limits, within the limits of family, and really promote and help them work as a family. We have some cases where the system failed. We don't have where to stash these kids that, well, in any point where if they have had any kind of problem, we know how about 2,000 kids, 2,900 kids that are protected, that are underage and protected, and about 300 underage kids that live in shelters. Also, with this mental health, we are trying to work with this educational part of occupational therapy to try and get these kids the help they need. This has helped us to see that our kids, our teens have more opportunities to have that process, to have a place so that they can be protected in their family or even outside from the family if needed. So this process helps us to get these kids and teens reinserted within the community so they don't feel discriminated. So the national patronage of infancy has a primary objective that these shelters be placed within the community. These shelters are normal homes, so they can assist us in school, assist the school as any other kid. I have this opportunity to make them participate in communities like the Scouts. I have all of these opportunities, all the opportunities that I can. We have to change a lot of stuff still, but this model makes it so that even right now we have never have had a person suicide when right when they're within our reach and within one of our institutes. That makes us think that we are really making a difference, because yes, we have those factors, all of the psychological, social factors, but we are really, really trying as far as long as we can to help these kids with all of this. We also have another institution called the Institute of Sports and Recreation. Which has currently the possibility to take a bunch of money to create all of these protocols and programs of education throughout all of the country. So we have our center part, the center part of the country, and the coasts that are normally not being able to reach as well of these programs. So we have this institution that worked on the protocol of prevention of suicide and risk situations that made these national games. And it was pretty great because it worked. It had the opportunity to present itself within all of the country. This institute has the opportunity also to work with how to attend all of the situations that can go all through all of these institutes. So it's pretty interesting how the institutes like these are working as in an assertive way for the prevention of suicide within our country. We have also the Ministry of Health that when, for example, when a person went out of the hospital for suicide prevention, we have to take into account all of these instances to really help this underage person that in a moment had these suicidal thoughts. All of these instances locally make it a little bit more makes it so that if you as an underage person with suicidal tendencies can be referred to and well having some kind of follow-up. So that a lot of local institutions can have that personalized, specialized follow-up. So this follow sometimes happens, but it doesn't always work because this overpopulation, this overdemand makes it so that maybe you go one time and you are asked to go again in 6 months, which is not really ideal to treat these kids. So we are trying to strengthen all of these institutions so we can continue and have all of these local institutions to really think, really to be able to make that proper follow-up and help them in a significant way. Need to be able to have that policy, to be able to validate these protocols on prevention of suicide. For example, we had the objective of being able to manage that protocol in situations of danger of people who live in shelters. That we started to work that last year. We are still working on it, but the Ministry of Health calls us to be able to be there in the capacities of this protocol, of the staff to be able to work these protocols, and to be able to identify all of these symptoms, signals, to be able to prevent in an early stage within all of our kids, all of our teens, all of these underage people. What we need to do is sensibilize all of the staff, all of these people that are going to be a part of this intervention to prevent suicide. We also need to tell them that, well, in the Ministry of Health, that, well, even if in one zone in the country, one person committed suicide, then the Ministry of Health goes to that community in particular and makes an assessment of what happened. How can they help so that it doesn't happen again? So what they do is that they take these programs that are some programs that are not all through the country, but that they take them to these zones specifically that are at risk, and they develop them there. So it could be that on one side, it is affected the physical health, like activity, they cannot do activity, sports, etc. But we also have this situation that mental health is not being promoted. So within the construction of all of this policy, this construction, we have a lot of problems. So at this very moment, we are now one of the first policies that are taking into consideration that every kid, every teen, take an account of what's happening within their lives. We have the particular chance to have a positive response for them. For example, what's happening to the LGBT community, we need to be able to have a response for them with a policy that has the best possibilities that they need to be able to exist. That's the same for the migrant people and all of the people in between. We have the opportunity to hear the voices of kids and teens within all the country, and that makes us response within the construction of this policy. That process makes us be able to create a policy to not be able. So we have this problem right now that us as adults are not able to keep this sexual education, for example, as one of these problems that we have. And we need to be able as and we need to be able to do that for them. It's really important. And the PANI as this institution that coordinates at such high level, we need to be able to work all of these really big tasks. We have here in, at least in Central America, we need to be able to identify like the different gender that they were born with, or other things that are right now really important and are really visualized within their teenage years that are not really being they're really creating a confrontation with their parents. So we need to be able to work very strongly with all of their parents, so they can really support all of these kids throughout the work we do with them. They need to be able to accompany them throughout all of the process, especially when they are really hurting. So, like educational level, we also need to take into account that they are being rejected by their teachers. This is when we need to make aside our ethics or morals or whatever we think about as an adult to help them. We need to have this empathy for them and be able to help them. We also need to know how to listen to work all of these spaces. Because we have the opportunity to intervene with their mom, their dads, to have this response with them. But how do we validate these spaces so that they can be positive and they allow that personal growth, that possibility of not having so much hurt? So because they can't adapt to what's already established. And so we need to work very strongly within this theme. The coordination of these institutions needs to really strengthen this work, because even if Costa Rica is very small, these spaces, and well, at least here within the capital, that can be used for recreation by underage people, they're being taken by adults that take drugs. So we need to coordinate a lot more vigilance from those spaces, in which, for example, the police can go to all of these spaces that we have for recreation. And so then it can be made that it doesn't, not everyone has access to it. And more now that after COVID, they have the opportunity to go out to have recreational activities, to play, all of this stuff. They can have this access and a life possibility. This turns into a risk situation. That, well, we can support them so that they don't stay home, stay on the tablet, stay on the phone, and they can go outside and have physical activity. As I was saying, just to reinforce it, that within all of this political process, we have the processes that allows us this follow-up, because there's a lot of demand and not much workforce. So there have to be a lot more programs that coordinate these spaces for the prevention of situations. And it's basically that, aiming to have better lifestyles. If we eat better, we have physical activity, recreational activities, meditation within our school spaces that can help this mental health. Keep the policies that currently that we are having. Because in the past, mental health has been kind of in the background. So now we need to really work on this. Really take action. And so some places have the opportunity to have policies at the level of that town specifically. So Costa Rica is working to have little spaces who are allied to kids. What does this means to have policies that helps to bring them recreational spaces that they can talk about their necessities, so that within that space they can go and say, okay, I think that park is pretty cool. I would like that to work with teens. In my hands, as a coordinator of all of this, I have this pulse to have a follow-up in all of these risk people who have drug problems, gun problems. What can we do to have all of these vigilant programs? These are many of the problems that we have as a country with within the within suicide, I try to take an account as everything that we have here in Costa Rica, and all of the programs that we have to on suicide prevention. And so this is everything I have. Thank you, everyone, and thank you for your attention.
Recording